Hello, everybody. I am Dr. Camran Nezhat. I would like to welcome all of you to this second webinar that we have. I am the founder of Worldwide EndoMarch and Endometriosis Day. And it is a pleasure and honor to have every one of you join us. The issue of coronavirus has changed the practice of almost every part of our lives, including the practice of medicine and surgery, and has forced us to find new ways to handle and take care of our patients. And this is one of those ways. We have a great faculty today to address some of your concerns of the issues related to endometriosis and coronavirus at the same time. And today specifically, we deal with pain and answering your questions. We have received many questions, and we will try to combine some of these questions. At the same time, if you have more questions, please send them and email it to us. Tiffany is going to send it to us, and we will address them. For our faculty, we have an excellent group of surgeons and physicians that are going to address your concerns, including Dr. Paul Vetter, the founder of the Society of Laparoscopic and Robotic Surgeons, and Dr. Ray Lanzafame, who is the CEO of the Society of Laparoscopic Surgeons and also Robotic Surgeons. We have Dr. Chung, who is the past president of Society of Laparoscopic and Robotic Surgeons. And we have Dr. Bogdan, who is a urogynecologist and is going to address some of your concerns in respect to endometriosis and also interstitial cystitis. And we do have my brothers and niece, Dr. Farr Nezhat, Dr. Ceana Nezhat, and Dr. Nezhat, who are the co-founders of the Worldwide EndoMarch and Endometriosis Day. We are all in the, and of course we do have one important person who is also a patient and also a person who has suffered significantly over the years because of the pain and has learned how to manage pain. Mrs. Janis Vetter, she would join us and she would address how to deal with pain when you have tried everything else and nothing is working. So I welcome all of them, and we will start with Dr. Paul Vetter and Lanzafame, and then each of them, they would address one area that when can we start seeing patients, and each faculty, because they are located in different areas and they practice in different cities, they will be able to tell you their opinion. When are we able to see regularly patients in our offices again? And when are we going to do surgery again? And what precautions do we have to start? of the any of the faculty who wants to start. Perhaps Paul, do you want to start?
Yes, thank you, Camran. I want to thank Dr. Nezhat for arranging this important meeting, and also for the amazing work that he's done over the years for the worldwide EndoMarch, which has attracted so much attention and done so much good to help people really understand about endometriosis and how it can best be diagnosed and handled. So thank you, Camran, for that, and also Ceana and Farr. You know, we're in the middle of an international pandemic now in crisis, and we're getting all sorts of news. And the question really that Camran raised is, when is it safe for us to start doing things again, and when can we return to normal? And more importantly, when can patients really expect to get their healthcare back to normal? Because the healthcare systems have been taken over by critically ill patients and patients with highly infectious diseases. And it's really put a halt on the use of elective surgery and taking care of other problems, even though those problems are still with us. And I think the answer to that really involves your own location. As we know, the coronavirus is really setting the pace for when we can get back to normal. We think that in most places now we're just past the peak. But a lot of what happens over the next couple of weeks really depends on each country and each state and how they handle us being sequestered at home and maintaining the rules that have been set. And if we all follow that, I would anticipate that within the next few weeks, we should see a dramatic decrease in the number of new infections, but that could vary from location to location. Certainly by the end of May, it's everyone's hope that things will start getting back to normal on a regular basis. But a lot of that depends on each person's location. So I think that's important to keep tracking that. There are two important things that need to take place. One is testing, and the other is tracking. And testing, of course, involves going somewhere, perhaps driving up to a hospital parking lot where someone can test you to see if you've been exposed. And the other one is tracking, knowing who's newly infected or who's been infected so other people can avoid them. And so those people can stay at home for a couple of weeks to be safe for everyone else. Ray, I know you have some other things to add to that.
Thanks, Paul. Thank you, Camran and colleagues for inviting me to this panel. I'm probably the only general surgeon, so I'll tend to field some of those questions, but piggybacking on what Dr. Wetter just said, getting back to normal is probably normal in quotes, and is something that is indeed going to vary by location. In the state of New York, within the past few days, they've begun to do some random sampling of people who've gone to shopping centers or grocery stores. Now, what that means is they were well enough to be out and about. And looking at that particular data, on average, about 14% of the people they tested had antibodies to COVID-19, which means that they experienced COVID-19. And of those, about 80%, 80 to 88% of those, so in the neighborhood of 11 or 12% of that population on average had COVID and had no symptoms. And I think that's an extremely important point. There's a very large population of people in all likelihood who've contracted the disease or who are out in public places without symptoms and yet potentially could be infectious. And looking at within the state of New York, what the range is, so that percentage of people range from about 21%, almost 22% in the New York City area, to about 4% in the rural areas of New York State. And that probably stands to reason as well, because if you've got fewer people congregating together, the likelihood of disease spreading becomes smaller the less contact you have with others. So that explains the shelter in place and the various lockdowns that are going on within the various states. So bearing that in mind, and yes, indeed, one needs to have more testing. One needs to behave basically as if everyone is potentially infected. And on the medical side of that, that's what we refer to as universal precautions. Once we get to an opening up or a transition toward normal, in all likelihood, that will be something that will be driven by individual localities. It also is going to depend upon what's going on in those localities, and is there a spike in new infections and new cases as things begin to open up. And opening up, at least in my area and in terms of quote unquote elective surgery, is something that at least one of the outlying community hospitals is talking about beginning to schedule elective surgeries starting the 28th of April. Now, scheduling a surgery doesn't mean actually performing a surgery, and they haven't defined what they mean by elective procedures or how they're going to go about it. The entire state is basically on a lockdown until mid-May, and that may well continue. If COVID behaves like influenza and other pandemics, there tends to be the main spike in cases, which most people believe that's what we're in various phases of now. And then things kind of drift back to normal, but then there are secondary and perhaps third and fourth wave spikes that depend on how rapidly people get back to their normal activities and don't take as many precautions, whether the virus circulates around the globe, and so on. So putting all of that into perspective, what that means in terms of seeing patients, most of us who are seeing patients are doing it the way we're doing it now, basically by telehealth, either by video or by telephone. In fact, it's discouraged to see people face-to-face unless it's necessary. And if it is necessary to see patients, the office staff needs to have personal protective equipment, PPE. Patients need to call first and be screened. And then prior to entering the office, they need to again be screened and have their temperature monitored. Now, remember I said there's a large population that have had the disease and had no symptoms. That would mean that their temperature is normal. And the party being examined would still need to be masked and so on during the course of the evaluation. Clearly, urgent and emergent cases are still ongoing, and I would suspect that that will continue throughout. But I think what you're going to see is what people, at least in my part of the world, are starting to call a new normal, which is probably something that is going to be masks, some degree of social distancing, some degree of separation if you're in physical continuity with others. And we are probably going to be in that phase, I would guess, for at least the next 6 months and possibly longer.
Thank you very much, Ray. So do you see patients now, or any of the panel? Please jump in and see how do you see patients, if any of you see patients, and what, and in what way?
It's Maurice Chung. I'm from Ohio, Cleveland Clinic, Canton Mercy Medical Center. I'm a urogynecologist, and pelvic pain doctor. In my practice, ever since the lockdown, I've been seeing maybe 1 to 2 day, half a day patients, and most of them were for the pain, pelvic pain, endometriosis pain, done no surgery. And I follow the guideline when Dr. Lanzafame mentioned patients have to get the temperature check at home before they come in, and then they'll check the temperature. We're going to give them a face mask, and of course, we all wear the face mask. So basically, I only allow the patient the type of those that if I don't treat the pain usually gets worse, and it will go back to where we started to begin with. So it's like an ongoing process to control them.
Thank you, Maurice. So any of the other members of the faculty, are you planning to see patients? What we are going to do in our case is that we are planning to, beginning this coming Monday, I live in California, in the San Francisco Bay Area. So there has been some announcement that we should be able to do elective surgeries. And thus, we are going to be following the following guidelines. First of all, if we are going to see patients, we ask them some questions in advance. We tell them if they have any temperature or any cough or any sign of coronavirus, or if they have been exposed to anybody who has had coronavirus. So if they have had any tests done, and if everything is negative, then and if they want to be seen beginning Monday the 28th, we are going to see selective patients. They come, and while they are in the parking lot, they text us that they are here. Then all the limited number of the staff and physicians are going to be all wearing PPEs, personal protective equipment, and we encourage patients to wear masks also. As they come in, we are going to direct them to the examination room, and we will proceed with the examination. And when the patient has left, then if we need to see another patient, we will see it that way. That is how we are planning to do. Also, the surgeries we are going to do, we are planning to do it very carefully in a way that in the receptions, the amount of contact could be very, very little with other people, and mainly with the healthcare professionals. So I see Dr. Bogdan Grigorescu also. Perhaps, Bogdan, do you have any recommendation? Do you see? And he is a urogynecologist also. Please go ahead.
Thank you so much. Can you hear me?
Yes.
Oh, great. Excellent. Thank you, Dr. Nezhat, for inviting me. It's an honor to be here. Piggybacking on what the panel said, we are practicing in a very high prevalence of COVID in Long Island, New York. And we've been very careful with our elderly population because we see urogynecology patients who tend to be postmenopausal, but we do see a lot of premenopausal patients as well. We are practicing in an office that where we see pregnant patients as well. So our office was never closed throughout this pandemic. That being said, we try to avoid our elderly patients being potentially exposed, but we have seen occasional patients who have needed our help, either patients who had pessary, had vaginal infections, who needed treatment, we couldn't delay them, patients who had questions about surgeries or concerns. And what's important, what we've done in our practice, we have basically closed our waiting area. So when the patients come in, nobody sits in the waiting area. Everybody gets seen right away after being screened with temperature. vitals, and they go straight to the examining room and try to minimize contact with the patient in a sense of our examining room are quite small, so we brought our patients back to the office to discuss any questions they have, and then they're going outside, and their family or partners pick them up in their car. So no family is waiting in the waiting area to minimize contact between patients and keep social distancing.
Thank you very much, Bogdan. So I'd like to ask some questions now. I think this is already settled unless Dr. Farr Nezhat and Dr. Ceana Nezhat, they want to say something. Then I will proceed with some other areas. There are a lot of questions has been sent in relationship to pain and also surgeries, number of surgeries, and also issues in relationship to pregnancies, IVF, etc. So I want to know if I see Dr. Ceana Nezhat or Farr Nezhat, do you like to say anything? Would you like to start?
This is Dr. Farr Nezhat. I add one more thing whatever it was said. I'm a gynecologist, oncologist, and we have been conducting our visit via virtual consultation. And in our hospitals, occasionally some urgent cancer surgeries have been performed with all the cautions. So in our hospitals right now, all the patients before the elective surgery are going to be tested for coronavirus. And if the surgery is elective and the patient has coronavirus test positive, so the case is going to be postponed. And if the case is negative, if the test is negative, then we proceed with the procedures. Also, if there is an emergency surgery and the patient has positive coronavirus test, there is a specific sets of operating room that the surgery is going to be done in those operating room. That is the only thing I wanted to add.
Thank you very much, Dr. Farr Nezhat. Dr. Ceana Nezhat, why don't you start addressing some of the issues of the pain? And there are a lot of questions that, for example, how many surgeries should you have for endometriosis? How many excision surgeries can you have? Would you like to address that?
Yes, thank you very much. I am Ceana Nezhat from Atlanta. Before I get to answer this question about how many surgeries you can have, I would like to invite Janis to give us a prospect from a patient who has multiple medical conditions and she's had numerous surgeries. Tell us how her experience has been and what is her prospect about surviving in an environment like this.
Yes,
thank you, Ceana. I come to this meeting as a patient who has lupus, which you're probably all hearing about with the Plaquenil and everything. I was undiagnosed for about 11 years. So like many of you out there, you didn't know what was wrong. You were struggling to find out. And what I can say is when you do get a diagnosis, that is your victory. That's the beginning of your plan to get better health. You need to mourn a little bit of some of the loss of your health. Know everything you can, learn everything you can about, in your case, endometriosis. You need to be an advocate for your own health. And what I mean by that is when you do find the doctor that is going to be part of your team, you need to keep your own health diary. You're one of many, many patients that your doctor has and sees, and you need to keep track of all your surgeries, your medications, the trials and errors of them, the symptoms, what you can take, what you're now not able to take. It's critically important. When you go to see your doctor for a visit, when we're all back on track, have a list of things you want to talk to the doctor about. I know in my own experience, if I didn't have that list and I went to the doctor's office, it all went out the window. So have a list, tell them you have things you want to talk about. There is no one size fits all for your treatment, as you know. There are many options, many types of surgery, and you need to keep a list of what it is you're having done and the questions you have for your surgeon. One good thing, and this is something I've done for 40 years once I did get my diagnosis, is talk to other people who have problems like you have. Helping others help you learn and helps you help other people. Listen to your body. If your body says, I'm having a really tough day, I have to rest, you rest. You do what your body tells you. You're not copping out. You're doing what you need to do to stay as well as you can. Don't put off tasks. If you have something that you were supposed to do and you're feeling great today, well, I'll do it tomorrow. Don't, because you don't know what tomorrow is going to bring. You have no idea of what's going to be around the corner. And have faith and hope and courage, because this is a long road. And if you do these things, you are more in charge of your health than you realize just talking to me right now. And I thank you for letting me participate. If anybody wants to ask any questions or get in touch with me, that's fine. Just the victory is finding out what's wrong, finding the doctor, setting up a plan, being your own advocate, keeping your health diary, and all those kinds of things, and talking with other people in similar situations so we can all learn from each other. Thank you.
Thank you very much, Janis. How often do you, over the years, when you take pain medication, how do you balance them and how do you change your medication? Or do you ever get resistant to one kind of pain medicine versus the other kind of pain medicine? How do you deal with that? How often do you change it? Do you use anything, alternative medications for pain? And what do you use?
Are you speaking to me? You were mute for a bit.
Yes, I was asking you, Janis.
Okay.
I was asking you that what would you, for over the years when you take pain medication, how do you deal with preventing getting addicted to pain medication? How do you deal with avoiding getting addicted to one kind versus the other kind?
Well, I've had, as you had mentioned, numerous surgeries related to taking massive steroids for pain over all these years. And I've had all kinds of things. And what I did with the last big surgery I had was I had my foot rebuilt because the bones were all, because of tendons and ligaments and everything, the foot collapsed. I kept a record of my goal, which was, okay, I have to be on this heavy medication and I want to be on it. I'll need to be on it for a certain amount of time, but I'm going to get off it sooner. And the one thing I learned was don't let the pain get ahead of you. Before you start, if you're supposed to take something every 6 hours, start thinking about it 5 hours. How are you doing? Because if you let the pain get ahead of you, it's hard to come back from it with the pain medication. You wind up needing to take more than you would normally. So you really have to be aware when you are on medication for pain medicine for a particular event, really keep track of it and start trying to wean down when you can.
Thank you very much, Janis. We appreciate it. There are some more questions coming in. As we go on, we would address it. There are some questions that they have asked us, and I was wondering if the panel would like to address it. There are several questions that our patients, specifically some of the patients in California, that have been asking that, is it okay if they can use some of the marijuana products like CBD oil or THC that now they are almost everywhere approved in all the states in the US, not everywhere, but almost everywhere. How, can they use it, and how should they use it, and what is the recommendation of the panel? Does anybody have any experience with it? Would they like to answer that question?
Camran, given my experience with light-based technologies and photobiomodulation, I get a lot of queries about that and various other complementary and alternative medicine approaches. CBD oil per se is pretty much marketable throughout the 50 states as far as I understand. It's not marketed, well, it's not supposed to be marketed as a drug, let's put it that way. But there are several ads that you can read in print or exist in other media that come very close to crossing that line, if not crossing that line. And those are things that the Food and Drug Administration in particular has landed on because none of these things have really been studied relative to their effect. So you can get CBD oil that you can put on topically. You can find it in food products. You can find it in food products for your pets. As some people have gotten some benefit from it, which I think kind of promotes the use in marketing. But I think the bottom line, whether you're using CBD oil, whether you're using THC or smoking marijuana, which is illegal in a bunch of states, you need to be careful with what you're doing, and you need to remember whether it's something that I'll call traditional Western medicine approved drug technology, whatever treatment, or whether it's something on the complementary or alternative side. If it sounds too good to be true, it probably is. And you need to be telling your healthcare providers what agents you're using, not just CBD or marijuana, but all of the supplements and so on, because they can affect your treatment. So I would say, yes, I've had some patients who've used them and have sworn that they are helpful. I've had some others who haven't, and we've all heard horror stories of people who've gone too far.
Thank you very much, Ray. I appreciate it. Now, if I don't know if the other members of the panel, they would like to say anything in this regard. Maurice, do you want to say something? Anybody else wants? If not, then Tiffany is going to ask some more questions, because a lot of questions are coming in.
I think Dr. Maurice Chung has an extensive experience being involved with the Pelvic Pain Society, and his feedback and input would be very helpful to our audience. Maurice?
I do that message on the bottom right. You can choose who it goes to.
Hello, Dr. Chung.
Okay, I got it. I'm still very new to this chat. Well, I do not personally prescribe marijuana, and I don't object my patient to use CBD oil or marijuana. And in terms of, I have seen some of those questions I think Tiffany sent out about the pain medicine. I typically do not give out pain medication like any of the narcotics to my pelvic pain patients or endometriosis. And when they have the problem with pain, well, of course, that we know endometriosis causing a lot of pain and endometriosis causing infertility. So in the pain group, we talk about what are the reasons why you have the pain. Is it just endometriosis? There are too many organ systems in the pelvis, including the bladder, including the muscles, including the nerves, the ligament, and the bowel. And endometriosis could be one of them and could be part of them. So basically, for pain patient, before I even approach surgery, I pretty much can decrease the pain level within, I say, 2 months. 80% of the patient would have 50% or more of the pain reduced without any surgery yet. And some of those, the pain would be completely gone. Of course, then I cannot say that they did not have endometriosis because I have not looked into that yet. So in terms of pain, through this pandemic situation, they come into the office, they said, my pain get worse, so I just try to figure out which part of the problem. And for those, many of them already have endometriosis, although I don't trust them, surgeon, because of they do fulguration surgery. But then when they have pain, that's the time I do not want to do surgery. And that answers some of the question, why is it some patient after endometriosis surgery, the pain gets so much worse after the surgery before they get better? Because the pelvis is on fire. And I typically treat the muscle, treat the nerve, and treat the bladder.
Thank you very much, Maurice. That is excellent. Maurice, what do you do for about patients with interstitial cystitis? What is your approach? And how do you diagnose them? Maurice, do you hear me?
Oh, okay.
Yeah.
Well, see, in the interstitial cystitis and in the urologist or gynecologist or the female pelvic medicine is a little bit different. The typical interstitial cystitis patient, they urinate a lot. They have the urgency. They go to urinate. And then shortly after, they have the urgency. If they don't go, they have pain. So, and they have multiple times, like 10, 20 times, 30 times a day, they have to go urinate. Now, those are very much, it's an isolated group of interstitial cystitis patients. In the past, IC patient was diagnosed by cystoscopy, hydrodistension, basically put a lot of water in the bladder and looking for the changes. But then, I think in about 10 years, 15 years, they changed it into the definition of when you have bladder pain, when your bladder is filled up with urine. So that's the painful bladder syndrome. So in the group, I found that painful bladder syndrome actually happened to be in about 85% of the patient. And so that's a lot. And in about 2002, which, you know, when I was still a resident, I was learning Dr. Camran, Nezhat, and Farr Nezhat's laser surgery. That goes back to 1980s. So we do a lot of treatment of endometriosis, and I found those patients happen to have painful bladder syndrome almost at the ratio of 1:1. The more I look into it, endometriosis patient, if the lesion is on the bladder flap, if the lesion were to be on the pelvic plexus, the hypogastric nerve, and on many other areas, they'll set off the urinary urgency and frequency. And then when I look into more, patient with interstitial cystitis, i.e. painful bladder syndrome, they have pelvic myofascial pain syndrome. So the muscle in the vagina hurts a lot, but nobody knows exactly why the muscle hurt and really don't have an idea to treat them. But then I look into more and I found out that in the pelvic nerves, the sacral nerve, S2, 3, 4, 5, invariably affected by the pelvic floor muscles, bladder goes through S2, 3, and 4. So then I isolated out in all these patients. I first go after the bladder in the office, giving them the installation therapy for 4 weeks' time. And I did the test on the first time to see whether the pain level dropped or not. Amazing, you'll see the changes. And the residual type of patient, when the improvement is 50% or they still want to get a little bit more, and I give them bilateral pelvic block. So that happened within 3 months time, and the pelvic pain level will be much less than 50%. And that's the time I take them to do one good surgery. And one good surgery, whether there's endometriosis, I take them all apart, remove them. And if the pain comes back after surgery, we know that that's the bladder pain, part of it, the muscle pain, pudendal nerve pain. And some of these patients will go to physical therapy. Now, that is the approach that I have. And I don't have people call me up at 2 in the morning and say, I hurt so much. Because those patients know that even though they go to the emergency room, they cannot do anything for them. That's a nutshell in 5 minutes.
Thank you very much, Maurice. Bogdan, do you have anything to add? How do you approach this?
Yes, thank you. So for our interstitial cystitis patients or painful bladder syndrome, so you have to distinguish that a lot of patients with pelvic pain related to bladder, which is suprapubic pain related to a full bladder and relief of voiding, a lot of patients do not have cystoscopic findings of glomerulations or hemorrhagic cystitis associated with classical descriptions in textbooks. You know, it would be nice to diagnose all the patients just with cystoscopic findings, but unfortunately, a lot of patients with pelvic pain, you look in the bladder and the bladder looks perfectly fine, and they still have a lot of pelvic pain. First and foremost, what we do, we have to rule out UTIs. We have to rule out urinary tract infections in patients who have any kind of pelvic pain related to the bladder. Once we rule out a UTI, we give them a questionnaire. It's a pelvic urgency frequency questionnaire, which correlates with some cystoscopic findings from studies done more than 20 years ago by Sant, Dr. Sant. So these are classic studies. In the old days, what they used to do, there was a very painful test called potassium sensitivity test, where potassium got instilled in the bladder, and the patient basically screamed loud and clear that they have a lot of pain when that gets instilled in the bladder. So we don't do that test, but the pelvic urgency frequency questionnaire, if they score more than 15 on that questionnaire, that correlates well with the potassium sensitivity test. So we diagnose our patients with questionnaires and a thorough history and physical examination. And then we may do also cystoscopy in the office or in the operating room. We try to instill in the bladder to maximum capacity, which can be under anesthesia. The bladder can support up to 1 liter of sterile water. So if patient has a chronic interstitial cystitis, their bladder capacity will be reduced from scarring, and we often see the bladder capacity often half that size with patients with IC, with interstitial cystitis, and with glomerulations and petechia, which are consistent with the diagnosis of interstitial cystitis. That being said, a lot of patients don't have cystoscopic findings, but they still have the bladder pain. It is important. It is very important for patients with IC to start performing dietary modifications. So we give our patients a list of bladder irritants, which can include fruits and vegetables, meats, caffeine, alcohol acidic foods, spicy foods that can irritate the bladder. So if they avoid those irritants, they can improve their symptoms to a great extent. At least 50% of patients can get improved just by dietary modifications alone. The patients who don't respond or who still have some pelvic pain, some bladder pain with IC, what we do is we do bladder installations. So patients who come in every week for 6 weeks, and we instill in a bladder a cocktail of substances that would soothe the inflammation in the bladder. In patients with IC, they have what's called a leaky bladder, where the substances from the bladder, with the urea and acidic components from that reach the bladder from their dietary intake, penetrate the bladder wall and get in touch with the nerves of the bladder, causing irritation and pain. So by giving them a cocktail of substances, which includes heparin, which is a bladder GAG analog, is a glycosamine glycan analog. Heparin combined with local anesthetic, with Solucortef, a mild steroid, and sodium bicarb mixed together by us in the office. We instill it in the bladder through a small catheter for weekly for 6 weeks. And we noticed with these treatments, about 90% of our patients improve significantly. That, coupled with dietary modifications, can lead to even more success for our patients with IC.
Thank you very much, Bogdan. As you can see, we have a lot of interest, but a lot of time, and time is running short because we were planning to do this for 45 minutes. We will go for 10 more minutes, and we try to answer some of these questions very quick and fast. Please, everybody give short answers and to try to answer as many of them. Tiffany, please go ahead and ask some of the questions.
Sure. So we received a lot of questions, a lot of them very similar. So one of the primary questions that we get asked a lot is about birth control and how long is safe to be on it. So we've received several questions just in general, as we know that that's something that's used a lot, you know, to help treat some of the symptoms with endo. So is it okay to be on it for a lengthy period of time? Also, is it safe to stop your period for a long period of time? Should you, stop doing that at some point? And, how could that affect you if you're doing that for a long period of time?
I can answer this question and also combine to a few other questions. In general, if a medication, regardless, because I saw some other medication also is mentioned, if a medication can control the symptoms based on the individual who does not have associated risk factors, and the risk of side effect is minimized by adding supplemental medication, the birth control pill or progesterones or any suppressive therapy is preferable over too many surgeries, aggressive surgeries. One of the audience said her diaphragmatic and lung symptoms have been controlled with medication. It's better to continue the medication. Birth control pill to suppress the periods is preferable if they can manage the breakthrough bleeding in betweens. Of course, birth control pill is hormones. It comes in the combination of estrogen and progesterone or progesterone only. It has to be individualized. Thank you.
People may experience less.
Okay, please go ahead. We have some more questions. And one of them I can actually address it quite fast. Some of the patients that have had pain, also they have infertility. And the question is, should they have surgery or should they take care of their infertility? And that all depends. It depends what stage you are. Patients who are younger than 35, they have a lot of pain and also infertility, and their husband's sperm count is normal. If they have surgery by an experienced surgeon who does thorough and good surgery without causing any problem, their chance of getting pregnant is excellent, even prior to surgery, prior to IVF. And there is good literature, good papers published in this regard, and Tiffany could send those of you who are interested. Even those of you who have pain and you have had infertility and you have undergone IVF, and because of sometimes IVF medication makes endometriosis worse and the pain worse, then you should not give up. Surgery by itself could treat the endometriosis significantly, not 100%, but you can have good results by proper surgery done, and you can have good results achieving getting pregnancy, even repeating your IVF after the treatment of endometriosis. And good data has been published in this regard also. So I let one other question that I saw, how many surgeries should you have for endometriosis? Endometriosis, unfortunately, is very enigmatic. We don't know much about it. We think we know, but the more we know less. Sometimes severe endometriosis causes no pain at all, nothing. And sometimes a small amount of endometriosis causes pain. And there are pathways, there are issues to deal with, but we do not help 100% of our patients. Unfortunately, it seems some patients need to have surgery very often. And after you treat the surgery, after you treat the endometriosis, let's say a year later, 2 years later, they do well for a while, and then endometriosis in some groups of patients reoccurs. And we do not know why. Is it an autoimmune problem? Is it suppression? Is it the food? And we don't know that. And also, that is another issue that there were many questions about that. So Tiffany, please ask one more or two questions before we finish the time.
Sure, absolutely. Another question that's come through a lot is in regards to diet. What foods should we avoid if we have endometriosis? Are there certain foods that we should be avoiding to help our symptoms? As well as, is there any proof that the endometriosis diet works?
May I answer to you a little bit? When I believe endometriosis happened to be almost hand in hand with painful bladder syndrome. And many of these patients do have irritable bowel syndrome too. So just you can pick out the painful bladder syndrome, those patients who prefer hot and spicy Mexican, Sichuan, Chinese food with a lot of apple juice, pineapple, vinaigrette, tea, anything with high potassium and stimulant fluid can act up the bladder. So now you act up the bladder, which is invariably act up the bowel because they are all in the hypogastric plexus. And with IBS, some patients have gluten allergies, so they cannot have any type of food with gluten. I can only suggest my patient with component of interstitial cystitis or painful bladder syndrome to stay away from that type of food, because even patients with endometriosis only, but when they have pain for so long, they will flare up the pelvic nerves and then causing problem to the painful bladder syndrome and the painful bowel. So yes, if anything, you follow the IC diet, and patient with IBS, they know what to eat, and they know what not to. Yes, there's a diet for it.
So Camran, I'd like to add one more thing about pain and endometriosis. We have to keep in mind that, as was mentioned, not every pain is in patient with endometriosis is because of endometriosis.
Right.
as Dr. Chung mentioned, and Dr. Grigorescu, bladder symptoms, pelvic floor, muscles, other issue has to be kept in mind. The other thing is very important for the patients to know. And as Dr. Camran Nezhat mentioned, it is a very complex disease. And some people that claim that excisional endometriosis is going to cure the endometriosis, they have to be cautioned when they use the word of cure. Endometriosis lesion, unfortunately, a lot of times comes back. And we don't have any panacea for this treatment, for this disease. The most important thing is in mind that we have to individualize the patient, as Dr. Ceana Nezhat mentioned. The best surgery is no surgery. Because in the best hand surgeon, in the best facilities, you may have side effects, complications. So we try to individualize the patient, find out the source of the pain, and try to implement appropriate treatment back for that particular person. Thank you.
That's very true, Farr. You just mentioned something is very true, because even patient endometriosis, they also have other things going on. The recurrence or flare-up may not be endometriosis, may be a painful bladder. And sometimes the flare-up may not be painful bladder, it could be the muscles and the nerves. So we have to find out exactly what bothers the patient and would have an algorithm that to sort this thing out. And too bad this year the SLS didn't have the meeting. I actually have 2 abstracts to submit it to that for just this algorithm. So that's how I approach. Surgery is the last. And after that, we know whether there's endometriosis or not, but sometimes when the patient did not even have pain, I would go through surgery and I found endometriosis, but the pain level was 0. Or sometimes I go in, I did not see any endometriosis. So that is the puzzle, what we all talk about. And pain is the pain. I deal with pain differently. Menstrual cramp is menstrual cramp. Then you can use the birth control pill to stop the bleeding and stop those pains, so I can proceed with the muscle and the bladder evaluation before I go right into the surgery.
Well, I'd like to thank all the participants. This has been a most fantastic meeting. As you know, we were supposed to be online only 45 minutes, and people that have already scheduled other issues to do and work to do, and we have already more than an hour. So we will, because there is so much interest in all these virtual conferences and I'd like to thank all the audiences first, and then I'd like to thank all members of the panel, Dr. Grigorescu, Dr. Chung, Dr. Vetter, Dr. Lanzafame, Janis Vetter, Dr. Ceana, and Dr. Farr, and also Tiffany Letsky and Zoe Pennington that organized this session. And thank you very, very much. There are many, many more questions. We apologize. We were not able to answer all of you. We try to answer them as much as possible by some of them by the email or call you. Thank you very much, and stay safe and have a fantastic weekend. Bye-bye.
Thank you. Thank you so much. Thank you.
Bye-bye.
Thank you. Have a nice weekend. Bye-bye.
Bye-bye. Thank you, everyone.
Bye-bye.